So for those of you that don't know me, I'm Nora Belcher. I'm the CEO of the Texas eHealth Alliance. I'll talk a little bit more about my background and my organization as I move through the deck. I really am excited to talk to you today about telehealth's role in improving health disparities and inequities, because I think the pandemic was sort of a seminal moment in understanding something that a lot of us in the field already knew, which is the unevenness of the healthcare system, the unevenness of the access to the healthcare system, never mind the outcomes. Got to get people in the system first. And the promise of telemedicine and telehealth, of course, has always been to change that. So a little bit more about me. I have been in public policy for a really long time. I always have had an emphasis on healthcare technology. I've worked at the Medicaid program. I worked in the governor's office for the previous administration. And maybe most importantly, I won computer programming contests in the 1980s, and my mother's kept those trophies for me. And here's me getting one. I think that's 82 based on the pants and the shirt that I'm wearing. I can make a ball bounce around on a screen on a TRS-80 faster than anyone in my middle school. And so I have always very much enjoyed technology. And I like to joke that I'm one of the original digital natives, because my dad was a fiber optic design engineer for what's now Alcatel-Lucent. And we had a computer in 1978 in our house. It ran on a tape drive. But my dad would talk about the capacity of light to carry information and how that would be transformational for not just healthcare, but the whole world. And he was completely right about that. Although we still have challenges, and I'm going to talk about that as I move through the presentation. Just a little bitty bit about my organization, in case you're not familiar with THA. We are the state's leading advocate from local communities to the national level for the use of health information technology to improve the healthcare system for patients. We're a 501c6, so a nonprofit, but not a charity. We are a trade association. As such, I have very strict antitrust rules and regulations that I have to abide by. So if you hate your EHR or you hate your telemedicine vendor, I'm very sorry, but you'll have to call them. I can't take those complaints. I can, however, talk about the system, which is my area of expertise. So I'm going to divide this into 3 chunks. I'm going to start with talking about the major policy issues before the pandemic. Then I want to talk some about the impact of the pandemic on the use of telehealth. And I'm going to focus on underserved populations, and particularly the issue of the digital divide, sort of where we sit with access to the internet, which quite frankly, you need to do telemedicine and telehealth in those circumstances. And then finally, the challenges and opportunities in terms of addressing health disparities and inequities. So let's start with rewinding. Now, I know it is hard to remember what things were like before March of 2020. I will tell you that for me personally, I actually had a surgery mid-February and was out for like 3 weeks. And I came back online and everyone was talking about COVID. And I was like, what's a COVID? I'm going to Google trying to figure out what a COVID is. We're starting to go into lockdown. So the transition for me personally was very abrupt. The transition for our industry was not as abrupt because we'd been doing this work for a while, but there were still some challenges. So I want to start with definitions, because I think it's always really important to talk about telemedicine and telehealth. You're going to see me using them interchangeably so that I don't make everybody stressed by saying telemedicine and telehealth all the time. But in Texas law, and I appreciate the link that just popped up in the chat, we have a telemedicine medical service, which is a healthcare service by a professional physician or health professional acting under supervision and delegation. We have telehealth, which is sort of everything else. We have remote patient monitoring, which is a one-way transmission of data that's then reviewed. The reason Texas has this distinction is rooted in an old fight that has essentially been resolved around prescribing using the internet, prescribing using a virtual visit. We have fought that fight over the decades in various shapes and forms. And that's maybe an easy way to remember those distinctions. Those that practice medicine can prescribe. Telehealth is sort of that broader ecosystem. Everybody defines it differently. States define it differently. Medicare defines it differently. And during the PHE, we defined it differently, which has caused some interesting ripple effects that I'll talk about here in a little bit. So always level set with definitions. I think that's really important. I want to talk about reimbursement and regulation a lot because those are two of the cornerstones of telemedicine being effective. It's not going to be the only thing I talk about, but I'm going to come back to these two concepts time and time again, because these were the places where we saw this enormous movement during the PHE. And the reason there's a black box on this particular screen is because I'm going to unveil that later. So I want to start with what the world looked like before COVID, in case you can't remember. And frankly, sometimes I do have to refer to my notes. Medicare fee-for-service was the biggest barrier and continues to be a barrier. Medicare services in telemedicine and telehealth were restricted to rural residents only and restricted to a limited set of services. And that was a big inhibitor. Medicare Advantage plans had a little more flexibility, still pretty problematic. And then you'll notice my repetitive statement here, large variation on what was covered. State Medicaid programs, state regulated insurance, federally regulated insurance, hugely different from place to place, from state to state. And I know the TRC staff will understand what I'm about to describe. I would get these phone calls from people and they would say, Blue Cross, they're not paying for telemedicine. I would say, okay, which flavor of Blue Cross? Is it a Medicare administrative plan? Is it a Medicare Advantage plan? Is it a Medicaid plan? Is it state regulated, self-funded? Well, I don't know. It's Blue Cross. Well, unfortunately, you have to drill into the policy and who owns the regulation across all these different silos. And yes, there's silos, even post Affordable Care Act, we've got silos. They're not leaving anytime soon, partially because of who's paying, right? Federally funded, state regulated, employer funded, federally regulated. Those things make a difference. So I can tell you that I have historically sort of heard from TRC staff in the early days that this was a huge challenge. Just working with people on what could get paid by whom, and then trying in the policy land where I work to try to get more and more things covered was a huge area of focus, right? And then you also have to think about regulation. So over the years, most state and health professional boards allowed the establishment of treatment relationships virtually. Texas was indeed one of the last because of some longstanding litigation between the medical board and a commercial vendor that we resolved in 2017. Although you could do it for mental health care a little bit before that. Over the last early 2000s into about 2010, we kind of got everybody there from a state perspective. We also have different licensing compacts in a number of professions, nurses and physicians. Those vary though in terms of which states participate, and they also vary in what they allow you to do. So the nursing compact makes it much easier for nurses to practice across state lines. The physician compact, which Texas just entered into this past year, is really an administrative acceleration of your paperwork to get your full Texas license. It doesn't allow for reciprocity across state lines. Lots of discussions about national licensure and or state by state reciprocity. Put a pin in that concept. That's very important, and we'll keep coming back to that over the course of the discussion. So from a regulatory perspective, this is what we were working with. This was also altered a little bit by a decision from the Supreme Court called NC Dental that involved the Federal Trade Commission, sort of saying to health professional regulatory boards, you can't have rules without a double check on them from somewhere like the legislature, your executive branch, because they were concerned that those rules would be used to stifle innovation and stifle competition. So this was a landscape in motion. We were all doing the best we could. I think Texas did some really good work. We worked in Medicaid for a long time. We've gotten our medical board to get on board, kind of gotten everybody to get on board, sort of just in time for COVID. So I want to stop there just to see if anybody has a question about the pre-COVID landscape before I pivot to the chaos of COVID and the opportunity that was in it. I feel like this is probably an audience that has some lived experience with that. So let's move on to the impact of the pandemic. And I'm going to break this down in some different ways for you to give you different slices and pieces of it. So this is my favorite slide because it immediately separates people into generations. There are people who know what this is, and there are people who don't. So in the 1990s, when the internet was relatively new to consumers, America Online sent CD-ROMs to everybody's house in the mail. And if you've heard me speak before, you may have seen this before, and you know my joke, which is that my grandmother thought it was a coaster and she put her iced tea on it because she didn't have a computer, much less a drive. However, what this really did was give regular people access to the internet. Now, it was the America Online internet. It didn't look like the internet looks now, but it was the first experience with You've Got Mail, being able to web browse, so on and so forth. That's important because COVID sort of did the same thing for both patients and providers that weren't already on board with virtual care. The role of the patient and the provider in terms of the expectations that virtual care is available was permanently changed by COVID-19. And that's not to say there aren't issues and challenges. However, it's important to also acknowledge that, woof, all of a sudden we had to turn the lights on. So what happened? Well, here's my chart with that black square removed. There was just this rush of activity. Medicare removed the rural restrictions. They added a bunch of services. Get online, get people their testing, get people their services, keep them at home, support social distancing, all those things. Same for Medicare Advantage. State Medicaid programs had to expand under their 1135 waivers if they didn't already have legislative authority. Now, I will tell you that Texas had passed some legislation that I've got on a later slide that had already opened up our Medicaid health plans to pay for a huge array of services. So we didn't have to put telemedicine and telehealth in our 1135 waiver. A lot of other states did. State regulated insurance varied because that's a tightly regulated industry. Some states implemented waivers, and some states plans stepped up voluntarily covered things. Self-funded insurers are always the challenge. And I know the TRC folks know this principle very well. A self-funded insurer you'll frequently hear referred to as an ERISA plan, Employer Retirement Income Security Act, I think of 1974. So almost as old as I am. That's regulated by the Department of Labor. And when stakeholders tried to say, hey, there should be some mandates on these employer-funded plans to cover telemedicine, the feedback we got, particularly from the Senate at the national level, was employers of all shapes and sizes are suffering also right now during COVID. We're not going to add an additional mandate onto what they have to do. So they are lightly regulated compared to the rest of the ecosystem. And it's been really tough to punch through that light level of regulation to get additional mandates implemented. However, for the most part, we saw this really big shift in reimbursement, which was great because the truth of the matter was, in some cases, elective procedures were canceled. We had to support social distancing in doctors' offices. We had immunocompromised people who still needed care, who all of a sudden had a way to get it that maybe their doctors weren't doing before. And if you'll remember, in the very early days of COVID, you couldn't get a COVID test without a doctor's order. So we had to use the telephone for a lot of those circumstances because our provider base was not ready to be online with video. And over time, that has shifted as well. So the reimbursement landscape really, really changed. And it doesn't mean that fight is over, but it was a significant shift. And in the regulatory space, we saw some similar shifts. So state licensing boards, again, opened up. The phone calls for treatment in the short term was, again, incredibly important because we didn't have audiovisual storing for capacity. There was also some discussion about, well, I mean, for how long has it been since you've seen your doctor for it to still be a treatment relationship, and expanding that look back so people could get COVID tested when they needed to and then get other services. Moving allied health professionals more quickly into the field to provide treatment under supervision, doing pain management refills over the phone, which for anybody who's ever heard the term opioid pill mill used in a pejorative sense, the Ryan-Haidt Act was softened a little bit also to allow chronic pain to be treated with phone refills and things like that. Some of that's probably not going to stick, but there was a loosening, and that was important to kind of keep healthcare going. Additionally, and Zoom actually fell in this category, the Federal Office of Civil Rights said, if you don't have a business associate agreement with your video platform right this minute, that's okay. Focus on getting services to people. But that's another one that I suspect is not going to stick around when the PHE is over. I'm not sure that Congress is going to be willing to waive the BAA requirement, partially because the vendors have all caught up. And my understanding is the healthcare products now offer that HIPAA compliance component of a business associate agreement. But in March of 2020, they did not necessarily do that. And people didn't necessarily know how to go get one. So OCR did the right thing, turned that off in the short term. I pulled together some statistics and I've already seen some in the chat. I'll share this deck and I've got links to the source material. Pre-COVID, we saw adoption estimates that were pretty low. That 28% number feels high to me. And sometimes in these surveys, you'll see patient portals counting as telemedicine and telehealth, and they're really a different thing. Hospitals were already much higher than physicians in terms of their adoption of these tools. In fact, I think that 76% in 2017 was probably maybe a little low. Post-COVID, interestingly, 80% of the doctors surveyed by our very own Texas Medical Association said they offer or plan to offer telemedicine as of their survey in April of 2020. I don't have a good hospital survey yet, but my guess is it's pretty much everybody. This has become a tool that is now ubiquitous in an awful lot of healthcare settings for a whole host of reasons. So that's enormous acceleration done very, very quickly. Some shock, right, involved in that, but also people discovering new use cases and new applications. A couple of those that I want to share before I move to the patient side has been cancer treatment and cancer survivorship. Cancer still compromised during treatment and even after. And so watching the oncology universe bring more of this to the table to keep people at home but still keep them connected to care was something I watched during the pandemic that I thought was quite extraordinary and exciting. Now, patient utilization. There's some newer numbers circulating. I'm sticking with these because they're numbers I feel good about the sources. 10% was generally the estimate we used for patient utilization in the prior days. Again, that 23% may include some other digital tools. I've seen numbers that show over half of Americans at this point have had a telemedicine visit. And you have to remember they spiked in 2020 and then they fell off. And there are some good estimates circulating. They're not online, but I can get them to you. In the future, most of the claims analysis shows we think we're going to get 1 in 5 visits being virtual going forward. So that's a huge shift. Think about the shift of 1 in 5 of anything from one environment to another. And you can see that this is really a permanent change to the ecosystem, the infrastructure, the way we consume healthcare, so on and so forth. I will also tell you there's starting to be some pushback on this utilization piece because people really do want to see this stuff bring value. So we had all that activity in the short term, building on the foundation that Texas and Louisiana and other states have laid. And then what did Texas do next? And I'm going to focus on Texas because the Louisiana legislature is a mystery to me. I think we have other folks that have that expertise, which I don't have. But I have a framework that I use to talk about telemedicine that applies, as far as I'm concerned, to any state, country, or program. I have worked with Singapore, the Netherlands, France, the Czech Republic, people from all over the world in this industry over the course of my career. And I was actually meeting with the government of Singapore, the health ministry, when I kind of came up with Nora's 3 R's of telemedicine. 2 of them you're already familiar with. Regulation. So in 2017, Texas finally moved fully into direct-to-consumer reimbursement, direct-consumer telemedicine reimbursement. So Senate Bill 670 was the one I was talking about when I said Texas didn't have to have a COVID waiver to do telemedicine and telehealth. We had already expanded coverage parity for telemedicine across our Medicaid health plans just in time. And that was a very useful tool to already have in place. And then my third R is rhetoric. And when I say rhetoric, what I mean is an overall ecosystem that is supportive of telemedicine, where it is considered a way of doing business, it's considered a way of doing medicine, and it's considered legitimate, and it's sort of integrated into your system. In 2021, our legislature made a lot of our COVID-19 flexibilities from our public programs like Medicaid, children's health insurance, children with special health care needs, permanent for those populations. What was really fabulous about this was that it was a low numbered bill, which meant the Speaker of the House gave it its blessing to be a priority bill. And I know everybody on this call is probably a little bit cynical about politics right now. So I want to make sure that I convey to all of you that House Bill 4 was a unanimous bill. We had Republicans carrying it, but Democrats as co-authors in both chambers. And we did not receive a single vote against the bill in the House or the Senate over the course of the legislative session, which was, by the way, the strangest legislative session of my career. Between COVID and Winter Storm Uri, it was not normal by any extent of the imagination. But even saying that, the fact that a telemedicine bill received universal support at a time of unbelievable high stress, partisanship, all these things tells you something. It tells you that we've arrived in some really important ways. It tells you that the legislature is really seeing kind of into what's possible. It was a big deal, and I really want to take a minute to honor Speaker Phelan, who really understood how important this was and gave us an upgrade. Also, the tech folks and others on the call from West Texas will appreciate this. Our House author was Representative Thor Price from West Texas. And so the joke all session was, don't forget 4 for 4, because our bill number was 4 and our House author's first name is 4. And it just goes to prove that legislators can have a sense of humor. They really can, they really do. I know that may be hard to believe if you're looking at the headlines right now, but good work, good public policy does happen. And it is happening at the Texas Capitol. It just isn't sexy enough sometimes to be in the newspapers. We also passed House Bill 1616 to enter Texas into the Interstate Compact for medical licensure. That was important because that bill had run up against some opposition from the Texas Right to Life. The pro-life groups in Texas had some concerns that were unfounded, frankly, that interstate licensure agreements would lead to abortion laws from other states becoming legal in Texas, which is not how it works. If you understand how medicine is regulated, we finally were able to put together a coalition to make a persuasive case, and it included MD Anderson Cancer Center and the Catholic bishops and some other very powerful folks that were able to calm those fears and make a persuasive case to get us into. MD Anderson, just so you know, estimated that it was going to save their cancer center alone $11 million for Texas to be a compact state. So there was a significant state fiscal savings for our participation in the licensing compact. So in 2021, I would say Texas legislature stepped up, gave us a lot of tools. Now, we don't have all the tools that we need. And so before I move to the next topic, I want to talk about Medicare for just a moment. The lack of certainty around Medicare, particularly fee-for-service, continues to be a real constraint on our stakeholders. Unfortunately, that rural restriction that's on my chart is federal law. It's not an agency rule. CMS has gone as far as they tell me they can go within their administrative authority. We really need Congress to act. And it's going to be very important that people step up, communicate to their local congressman, congresswoman, congressperson that this stuff matters, because it does. There have been some excellent claims analyses done to kind of show that this is cost neutral to cost beneficial to the federal government. So the data is there, but there's concerns about it being abused that I'll address later in the presentation. Just don't forget, Texas doesn't control the Medicare program. And new legislators, sometimes it even takes them a while if they don't have a healthcare background to wrap around the difference between Medicare and Medicaid. Texas controls Medicaid. We have a lot of flexibility. Medicare, on the other hand, we really need Congress to take action. And I'm cautiously optimistic. There's some vehicles for a deal between now and the end of this year. It kind of depends on when the public health emergency ends, which I know you've already had some discussion about that today. This is where we sit. So from a regulation perspective, we're in pretty good shape. We'll keep most of the flexibility in place, not all of it, but most of it. Reimbursement, there's some wild cards, ERISA plans, Medicare fee-for-service. But in terms of what states can control, I think states have been pretty successful in looking at these models and saying this really works for our citizens. We want to keep it in place. And some of that has to do with the high levels of consumer engagement and consumer satisfaction. So all that sounds great, right? We're winning, we're moving, it's all good. What else is there to do? I get asked this sometimes, like, hey, can't you take a vacation now? Can't you relax? All the work has been done. There's no more work to be done. Anyone who is saying that to you is not paying attention to the ecosystem in terms of both the work that's left to be done and the opportunities to make improvements in the healthcare system using these technologies. So let me make another pivot and move into the concept of social determinants of health. Definitions are incredibly important. They're not just important in legislation, but they're important in the way we communicate and convey concepts. So social determinants of health, simply put, are the conditions in which people are born, grow, live, work, and age. There are a number of definitions. The American Hospital Association uses one that's a little more detailed, that has the classic 80-20 split. 80% of a person's health and well-being is tied to these factors. Maybe 20% is tied to access and quality of care. Kaiser has looked at this and broken down socioeconomic status, education, physical environment, employment, social support networks, alongside access. So this is really stepping up, pulling out, and looking at the bigger picture of care. This is an incredibly important concept. And it's not new to some of you, and to some of you, so be kind of wondering, like, what's this all about? It's also a definition that's changing even as we speak. I was in a big multi-institution higher education meeting on Friday, where I learned that there are people advocating to move away from the term determinants and use the term drivers instead. And some of this has come out of focus groups where patients have given the feedback that determinant makes it sound like they have a choice. It's already been determined. So that drivers might be a better choice of word, because it can reframe the conversation into things that can be controlled or impacted or influenced, instead of just saying determinants. You can also break it down into individual drivers and social drivers. So I'm going to say SVOH, and you can fill that into your preference. I was talking about this with a student intern that's working with me today, and he said in the UK they use social disparities or dysfunctions. They use yet another word that's got some negative connotations. So to each their own in terms of language, but we've got to standardize it somehow. And so I'm going to stick with SDOH for the duration of this presentation. And specifically, what I want to do is drill down on the digital divide. So it's great to have your doctors have telemedicine. It's really fantastic to have institutions like Texas Tech doing all this really amazing work. However, if people don't have access to technology, that's a problem. So I'm showing you some old data. It's so old. It has MP3 players and iPods as a category. But I want you to take a look at, just over the course of a year, the adoption changes across some of these populations that are low income in terms of technology from a decade ago. It's Pew Research is amazing. And if you're not familiar, I will warn you right now, you will spend hours going through their stuff because it is incredible. It's my primary source for this data. Their methodologies are super sound. They do great work. But you can see, even over the course of just a year, even in our lower income category, a decade ago, we were seeing jumps in adoption of technology, starting to be some abandonment of desktops, game consoles, DVRs, trying to figure out what are the tools that we're going to use. And this obviously, while it's dated, it's important because it gives us a benchmark for where these folks were sitting. This is important because if people don't have an on-ramp to the internet, unless you're doing remote patient monitoring with a device, a lot of telemedicine offerings, unless they use the telephone or something else, are simply not going to be accessible. So it's important to understand where these populations are coming from. This is more recent data from 2021, again from Pew. Even in our lowest income bracket, if you look there at smartphone, that stayed relatively stable from the 2010 data. Desktops are obviously more ubiquitous in the higher income categories. Home broadband, I'm going to talk about this some more. This was the place where we really found the growing pain and the opportunity in the COVID response. Because if you look at that dark blue bar, only 57% of those lower income households had access to home broadband. And even in the neighborhood I live in, which is houses built in the 70s, that are, they're nice middle class homes. We had school buses with Wi-Fi hotspots trying to support children going to school and parents going online to work and not having enough access to the internet. Tablet computers, still not super popular. But even 1 in 4 low-income households has all the above. So there are folks that are online. I don't want there to be an assumption that just because you're in a lower income household, you aren't and you don't have technology. But at the same time, if you take a look, you can also see that we still have a percentage of those households that are not online at all with any sort of tool. They might still have a landline. They might not have broadband access. They might not have reliable cell phone service where they are. And there's a spot that I drive on every day on my route home that drops my cell phone call, and I have to warn people, going under this bridge, it's going to drop the call. You're going to have to call me back. If I'm talking on my hands-free, for those of you that are worried I'm holding the phone to my ear, I'm not. And I try not to make a habit out of it, partially because I know my call is going to get dropped. So when you put all of this together and you think about health disparities and you think about SDOH, the folks that we really want to reach in a lot of these circumstances are going to fall in these lower income brackets. So wanting to use digital tools means we have to really be attentive to these gaps that the digital divide has exposed. There is also disparities between white adults and Black and Hispanic adults. Some of these numbers are pretty close together. For example, if you look at smartphone adoption, they're very even. Tablet computers, very even. However, you can see that our Hispanic communities are really lagging behind, and particularly the home broadband access. There's a pretty sizable gap there. In the all of the above possession, which I would submit to you sometimes is very useful when one of your tools stops working and you can just switch to the other. Reliable broadband, though, without it, a lot of this stuff doesn't work nearly as well. We also know that the smartphone is frequently the only tool in the household. The numbers tell us that. And smartphones are computers now. Now, not everybody has a full fancy new iPhone or a Galaxy phone. Some people are still using trap phones, using old phones. And so we have to keep that in mind too. Even if they have a smartphone, it might, for example, have a limited number of minutes. And one of the policy issues that has been flagged nationally is, can we find a way for those minutes to not count against people's plans if they're accessing healthcare? Because what we don't want is to get somebody who's in need of help on a call on their cell phone and have the cell phone drop because they've run out of minutes. That seems to be the sort of problem that we ought to be able to solve. So my partners at the Center for Telehealth and eHealth Law in DC are taking that on as a policy issue, trying to figure out how to essentially craft a solution to take on the idea of capped minutes. Home broadband can be expensive. There's that whole issue that you have with the first year price is lower, and then they come back and they're like, oh, now you're a regular customer, your price is going to go up. My mother is perhaps notorious for threatening to fire her home broadband provider every year. She goes in person, she takes the box, she makes them cut her a deal. Good for you, Mom. Not everybody has the time, the transportation to take care of that. So if they want home broadband, sometimes they can be stuck with a price that's not affordable. So there's a whole bunch of things there that have to be taken on. This is important to understand because, again, what we know is that COVID disproportionately impacted these communities, and we're still learning why. I saw a news report the other night that it's possible that pulse oximeters don't read darker colored skin the same way they read lighter colored skin, and that might have messed with some pulse ox readings that were important for the diagnosis of COVID. There's a lot of work yet to be done to bring everybody up to the same level. And we have to pay attention if we're going to advocate for the use of telemedicine and telehealth. We've got to make sure that people have the tools in their home that they need, no matter how we get them there, and the access to the internet that they need to be full participants in the digital ecosystem. There's another group I want to touch on because these are folks that are often perhaps not thought of as frequently, and these are Americans with a disability. I found these numbers to be a little bit sobering. because the differential, statistically significant differential for desktop smartphones and home broadband and all of the above is pretty significant. They seem to have pretty good, people with disabilities have pretty good home broadband adoption. Obviously, they don't have or don't use smartphones at the same level. But this is, again, a group of people who need healthcare. Pandemic or no pandemic, if you are an American with a disability, your access to your healthcare system is incredibly important. So we really want to make sure that we are thinking of these populations as we build our tools, as we build our infrastructure, as we build our applications. And that's everything from making sure that websites are ADA friendly to making sure that there are interpreters available. Sometimes they can be built in. Sometimes you've got to have a live person. I was absolutely delighted to watch, because I'm a space person. I love outer space. The announcement of the photos from the new Webb telescope yesterday, the president had a press conference, and they had a sign language interpreter, which I thought was just brilliant, to make sure that anyone who was watching but couldn't hear was able to watch that presentation. This is an important population. And again, we want to make sure that they are not left out of these conversations about the digital divide. I think sometimes there's a tendency to think that, oh, well, everybody has a computer, don't they? Or everybody has access, don't they? If you're at a point where, let's look at home broadband, 72 to 78% still means almost 1 in 4 Americans could be left out. That's a lot of people. And we really have to pay attention to those things. And I think there's a lot of money, a lot of investment in closing those broadband gaps right now. So I'm not saying it's off policymakers' radar screens, but I am saying when we talk about the growing pains and the opportunities for telemedicine and telehealth, we have to make sure that we think about infrastructure, and we have to make sure that we focus on that digital divide, because it's incredibly important as a conversation. I also want to talk about broadband speed. So most of us are still stuck because the federal government, the FCC, has not updated their broadband definition in quite some time to say that a 25 megabyte download and a 3 megabyte upload is sufficient. I can tell you right now it's not sufficient if you got multiple people sharing home broadband. We have underserved households. We're doing great with lower speeds, but when you talk about maybe 50 by 5, or if you want to future-proof it, 100 by 10, you really start to find unserved rural households. And again, you're getting close to that 1 in 4, that 1 in 4 number. And yes, we certainly have places in rural Texas that they have nothing. There are places with absolutely no service. I've seen legislators hold up their cell phones at town halls and not be able to get a cell phone signal, which was a little bit embarrassing, I think, to the internet carriers in the room. So we know we have gaps. We still have places that only have DSL. And the other gap that I find kind of fascinating is also we have what's called dark fiber. So this is unused fiber. And some of this has come from grants, well-intentioned grants, but they were only for the library. They were only for the school, or they were only for the hospital. And we need to be continuing to do the work to figure out how to share those resources and then get the unserved rural households online. This is a gap. And again, if you're talking about access to broadband is now an SDOH, because from a telehealth telemedicine perspective, the phone has limited capacity. It can provide services. I'm not saying that it can't, but they can't provide everything, and they certainly cannot bring the things that video and other things can bring to the table. So here is a huge gap, and it's really problematic. The good news is the legislature and the federal government have made multi-billion-dollar investments in addressing this. We now have a state broadband plan. Other steps are being taken to kind of shore it up, and that's happening all across the country. So we should see some improvements. I just hope they're built future-proof. I actually don't want to see 25.3 run anywhere else if we can run 55 or 110 and be done with it, because that will buy us some time and some space and not have to do it twice. I also thought this was fascinating because I was such an early internet adopter to see the percentage of US adults who say they don't use the internet. They exist. Now, this is not people taking a social media break because social media makes them tired. This is people who just say they don't use the internet. Small percentages, some variation across race and ethnic groups. Obviously, when you get to 65 plus, we see not an unexpected gap. And again, that's not to say people 65 plus can't use technology and can't use the internet, but they may be choosing not to. They may be in a place where they don't have access in rural Texas, or maybe in a facility, or it just may not be of interest, or they're not convinced of the utility, or they can't afford it. So if you take another step down and you look at that lowest income tier under 30K, you certainly are going to see that's the highest percentage of people saying that they don't use the internet. There also is clearly some variation in terms of education, which is not a surprise. And then again, more folks that are rural. So do not use the internet can be for different reasons. Don't have access to it, where there's no service, don't want it, can't afford it. Those things are addressable, but they're not addressable easily. It takes conversation, it takes coalition building, it takes investment, it takes use case. I'll give you an example of a use case that I found fairly transformative in my own family, and I have his permission to tell this story. My father-in-law, who is almost 90, and he went to Texas A&M, so he's an Aggie, discovered his physician's patient portal not too long ago and thinks it's the greatest thing in the history of the world. And so his skepticism of the internet kind of flipped into, okay, here's a tool that I can use that makes sense to me, that has my information. And he would do a telemedicine visit if it was in his portal, because he's comfortable and familiar with that as a tool. And he's given me permission to say if an Aggie can do it, there's an awful lot of people that we could get there. But to get them there, we have to understand what the gap is. The gap could be no service. The gap could be a choice. The gap could be affordability. Like I said, it can be various things, but we also be careful not to stereotype. I think particularly with the older Americans conversation, access to the internet, not just for clinical healthcare, but for social interaction, is a high priority for groups like AARP that represent older Americans. And I don't think that conversation is going anywhere as the baby boomers really start to age and hit their high utilization years. So I do expect to see shifts in this over time as the cohorts move forward. But for the point in time discussion we're having now, the impact of COVID, I want you to look at the date here. This survey was taken in 2021. So we were into COVID, where being online, doing telemedicine, working from home, all these things suddenly became relevant to huge swaths of Americans that it was never relevant to before. And yet we still have populations that are not online. I'm also very curious about who the 18 to 29-year-olds are that aren't online. Very curious about who they are. So this is just an interesting, another slice of the Pew data. And again, if you're not familiar with their research, it's extraordinary to think about who fell in the gap. Where does the digital divide hit us? It hits us at an individual level, it hits us at a household level, and it can hit at a community or even a regional level if there's not good, reliable access to the internet. It's incredibly important. So it's essentially a social determinant or driver of health now. So when we take all of that into account, what does that mean? What are the challenges that are left? What are the opportunities specifically around addressing disparities and inequities? So I want to go there next, but I want to see real quick if there's any questions about all the survey data that I just went over before I move more into a policy recommendation discussion. I like data, find it useful, find it helpful.
I love that data too, by the way. I thought that was great data, great use of it to really using that data really leverages the conversation correctly when you can say, based on this data, we know what's going on, and it's a great source there. So
thank you, Derek. I will say I literally carry a Rubik's Cube around at the Capitol, just so everybody can see it. I have them with my logo on them, because what frequently happens with policymaking is we only solve for one side of the Rubik's Cube, and it leaves the rest of the sides scrambled. So you can have a policy solution that only addresses one of those data sets. And it's great to address one side of the data set, but you really have to be looking at the whole picture. And I think access to the internet, I think people made a lot of assumptions about where Americans sat. And that's not necessarily the case. And we found that out the hard way during COVID. So now we've got to take steps to address it. And I also think sometimes we forget about some populations. The data on Americans with disabilities, as a former Medicaid person, that really struck me, because there's so many things that we can do to support those populations with technology, but they've got to have access. And if they don't have access, we're just sort of shouting in the wind.
And 15 years ago, I married a farmer's daughter from the middle of nowhere in Texas, and I didn't realize that was going to mean that I was going to move out to the middle of nowhere in Texas. And 8 years ago, when we moved out there, there was only one internet provider, and it was very slow. We got about 8 to 10 megs of internet, and I thought, well, you know what? Things are changing and moving and growing. I'm very close to town. I'm like 15 miles away from town. I'm not that far out from town, and I thought, well, for sure, we'll get better internet. And 8 years later, I still have 10 or 12. And I looked into it. We talk about dark fiber. There's a lot of dark fiber buried on the land that I'm on. And I looked into what it would take to access that. And it's really difficult, and it's really hard to get in touch with people. And so I love that you brought that up, because that was like a personal pain point for me, is that I went through that exact thing. And right now at my house, there are people building an 80-foot tower so that I can be an internet service provider for my area. And they're building it right now. So hopefully it'll be done here in about 30 days. And that's what I've had to go through to get internet in rural part. And I'm really not that far outside of town. So.
Right. So first of all, as the daughter of a fiber optics engineer, dark fiber is just offensive to me. Why is it there? What is it doing? Somebody paid for that. Why aren't we using it? And of course, we know this about government and grants, right? We fund in silos. And so there's got to be a conversation about what is the benefit to the broader community for turning that on and making it useful and figuring out how to make that work. So I think that's important. Derek, have you thought about tweeting at Elon Musk and see if he'll turn Starlink on for you like he did for Ukraine? Because he seems to be into that sort of thing.
He did actually give me some Starlink access, and I was looking at getting the access there. And so I had just gotten my email from them saying, hey, you're approved for Starlink. You've been on the waiting list. You paid your deposit, and I was about to turn it on. And then this other company that I'm working with finally contacted me and said, hey, we're ready to go ahead and get this tower built. So I'm kind of going the other way with it. So
Gotcha.
Starlink would have helped me, and I would have had good internet. But what I'm doing now is going to help, roughly 2,000 people around me get good internet. So.
Right. Yeah, I get a lot of questions at the Capitol about why are we running broadband line when there's going to be Starlink. And my first response to that is generally Elon is mercurial. So, we've got to kind of factor that in. Although I think disruptive technology pushes innovation across the board. So I am in favor in general of those sorts of disruptions. And I just think the books that are going to be written about Elon Musk in 10 years are going to be wonderful reads for all of us, because I have no idea how that story ends. Speaking of how the story ends, let's move into policy. My favorite thing in the whole wide world besides outer space. And let's talk about reimbursement. So we're back into Nora's 3 R's. First of all, I think it's important to acknowledge that utilization is down from the peak, and these services need to get more integrated and more predictable for patients. So again, we think 1 in 5 future visits will be virtual. Provider adoption, patient interest is high, so that's a benefit. Program integrity concerns are serious. Let me talk about that for just a minute, because when I talk to congressmen, congresswomen, senators, House members, the number one thing I hear is, Nora, I'm really worried about this telefraud stuff that they're finding. So if you really dig into this concept of telefraud, what you'll discover is call centers getting their hands on people's information and using it to bill for fake DME. And no legitimate telemedicine, telehealth company, stakeholder, or advocate thinks of that as telemedicine and telehealth, but it's been labeled telefraud. So high-cost DME and high-cost prescriptions are going to be 2 places Congress is really going to be watching closely to make sure there's not fraud. Medicare fee-for-service has fraud problems. It's not unique to telemedicine, but it is the sort of thing that kind of splashes some cold water a little bit on the way that people think about using these tools, particularly in public programs. So program integrity, anti-fraud is real and it's legitimate. And as an industry, as an ecosystem, we sort of dismiss that at our peril. We have to model good compliant behavior across the board with billing and all the other things. So the bad guys really stand out as bad guys. And then finally, and I think this is incredibly important, as we continue to move to value-based purchasing, that is going to create stability for telemedicine and telehealth. And what I mean by that, some of you have heard me speak a bunch of times, and some of you are hearing me for the first time, but I will tell you that I've been teased in friendly ways by my colleagues that they want to do a bingo card of things that Nora says all the time and hand them out when I give speeches. Probably fair, might be kind of fun. One of my bingo card squares says fee for service is the enemy of telemedicine. And the reason for that is because in a fee for service world, telemedicine, which increases access, gets more visits, right? Instead of 5 visits, there have been 10. Instead of 10 visits, there have been 15. And if you're only measuring the impact of the increase in visits, and you're not looking at the overall health of the cohort getting the service, it looks like we drive cost. And I hear this conversation at the Texas Capitol all the time. The good news is that the Health and Human Services Commission took a look at this prior to COVID in the fall of 2020, and they were able to show that the Medicaid cohort getting telemedicine services was in the hospital less and had less ER utilization than the cohort similarly demographic that didn't get telemedicine. That was fantastic news, because that's what we all know pretty much about how it works. But to have Texas Medicaid show it with their own data had a lot of value. They're going to replicate that report this fall with COVID data. I'm going to be very interested to see how they put everything in context from the peak of 2020 kind of sliding down into this normalization and integration. Whenever you can put telemedicine and telehealth inside a bundle, so maybe a package that a plan is paying for a knee replacement, and it doesn't matter how many visits there were, as long as the knee replacement is successful, it takes away the sort of bean counter. I'm doing that in air quotes because I don't want to be too mean, but measurement of visits, measurement of 10 visits. That's frustrating. And that's always been the cap, right, on the growth of telemedicine and telehealth. It's the cap for the Medicare discussion. Part of the reason Congress is struggling is the Congressional Budget Office keeps scoring removing that rural restriction as a cost. And a lot of good work is being done to counter that and provide additional data, but the CBO at the end of the day gets to score the bills, and removing the rural restriction from Medicare is the single most expensive thing on the table in terms of changing the Medicare program in a permanent way. The more value-based purchasing we do, the better. Unfortunately, Medicare is still primarily fee-for-service. So it's a great opportunity to get this stabilized, but it's really got to be part of the value-based purchasing quality conversation. And when we do that, we take those little off of the way that we're providing services. We make it more stable, because right now I know for a lot of providers, because I get the phone calls and I know the TRC does too, it still feels very unstable despite all of our successes, which is very frustrating. I don't blame anybody if they find all of that frustrating. I certainly do. However, the news is more good than bad. Just we can't celebrate. We don't quite have it all done yet. So that's sort of where I see conversations about reimbursement moving, particularly in Medicaid programs that are moving to value-based purchasing. I think that's important. And quite frankly, had we moved into value-based purchasing sooner, I think telehealth's ascension would have been stronger prior to the pandemic. There also has to be an effort to assess what worked during the pandemic. This is incredibly important, that we publish if there's data available. I know a number of folks that are working on publishing success stories from telemedicine implementations from the pandemic, keeping models that show patient benefit, and then expanding that broadband and those other services to address the digital divide. All of that becomes really important. We do have subsidized broadband available for Medicaid recipients, for example. In Texas, you can qualify for very low cost broadband. Those programs don't have the uptake that I'd like to see. So some of this just may be as simple as communication. And then in the long term, we have to continue to move along this track into patient-centered care. And that includes having the right codes. One of the big frustrations for me in my career, and I started working on this stuff in 1995, What is that we use the same codes and we add a modifier. And the telemedicine experience sometimes is the same as the in-person experience, and sometimes it's something different. They're not always exactly the same. Now, from a clinical perspective, you want to meet the same standard of care, but I also think there has to be work done on codes that reflect the things that we do that are innovative and creative, and that needs to move a little faster, because I can't tell you how many times I've seen an innovation and then been told, well, there's not a code for that. Enormously frustrating for everybody involved. So the more we can frankly use analytics, data to accelerate the development and adoption of appropriate codes and reimbursement of new care delivery models, value-based purchasing, bundled services, those sorts of things. I think that will I see a question in the Q&A. So Derek, do you want me to hold those to the end? Because it's not specifically related to the slide that I'm on.
We can hold it till you're ready. We
Okay.
can wait, or we can answer them as you want.
I'm going to drop that down and pick it back up. So person who asked, I'm not ignoring you. I want to get these concepts out on the table, and then we'll get to questions. Let's talk about my second R, which is the regulatory component. The providers certainly want to see COVID waivers extended, state law amended for more licensure flexibility and reciprocity. This is a sticky constitutional question, and there are some really significant open questions about the right federal mechanism for the federal government to pull to do this. For one thing, health professional regulation has traditionally been seen as one of those not specifically given to the federal government, therefore delegated to the state sorts of powers like police power. CMS can do a lot of things, but can only directly impact Medicare and Medicaid in a lot of ways. They can't really get to medical boards, don't fall under the purview of CMS. Sometimes people say HIPAA. Well, HIPAA regulates data and the providers that carry data, but doesn't regulate medical boards. So there really are open questions. There are very good arguments being made that the interstate commerce clause that gives the federal government the power to regulate interstate commerce could be at play here. There's probably some truth to that. The states will certainly push back. So this was a complicated argument. When I talked earlier about Texas entering the interstate compact for medical licensure, I mentioned that we had some struggles back in the day, a couple sessions ago with Texas Right to Life. This is now caught up in Supreme Court politics following the Dobbs decision. So this question, which has always been a tricky one, has now become even trickier from a political perspective. And I don't think there's going to be an easy answer. And it's gotten to the point where there was a story in Politico the other day, and I'm happy to share the link. I don't have it in front of me. The telemedicine lobbyists wouldn't even go on the record about how these politics are sort of impacting the progress that we've made. So I have made a decision to acknowledge those dynamics in public presentations, because I feel like any overview of what's happening is incomplete if I don't do that. I'm going to be very clear. I'm not taking a side in terms of this, what the Supreme Court did, what the state of Texas is doing, what other states are doing. What I am telling you is sort of the facts of what the field looks like when you start to talk about reciprocity, when you start to talk about compacts for medicine. It just got way more complicated. And a national license feels to me personally farther away than ever because of politics that have nothing to do with the industry I represent or the ecosystem that I do work in. And that's really unfortunate. And again, not saying unfortunate about the decision itself, not weighing in on that, but just making the observation, as many other people have, that this regulatory piece is now way more complicated. And it was complicated during COVID. And it's now more complicated. So that's just something that you need to know, no matter where you sit on the political spectrum. It is what it is, as they say. As my teenager used to say when I asked him to clean his room, it is what it is. I want to talk for just a second about the digital divide and break it down a little bit further, because I think these concepts are also important to share as I move into social determinants of health. The digital divide is basically the inequalities between computers and online access, people that have it, people that don't. There's a concept called digital equity, which I really like, the idea of leveling everybody up to have the capacity for full participation in our society, democracy, and economy, which is incredibly important. And then digital inclusion speaks to groups like Americans with Disabilities that I was talking about earlier, to make sure that everybody has the access that they need to use information and communication technologies. These are relatively serious, scholarly studied topics that are making their way into policy land, which I'm very excited about, because honestly, to really get to solutions, you have to take on all three. You have to acknowledge there's a digital divide, you have to build towards digital equity, and you have to make sure you address digital inclusion. And if you do all those three things with your strategy, including inviting those individuals and groups to the table for conversation, not just talking about them, but talking to them, which I make part of my practice because that's incredibly important. You can make some progress. I also want to mention that one of the things we're talking about is doing a gap analysis of broadband access as part of the new state broadband plan, and I put a hyperlink in there. The comptroller's office was required to publish a broadband plan, and we were one of only 6 states that didn't have one. So that was excluding us from some federal grants. We have to make sure that we find the areas of highest need and get to those. We also, like I said before, have to make sure we work on digital literacy. There's some great work being done by United Way and other community-facing groups in helping people get online, which at the end of the day is a one-on-one conversation. It requires manpower and it requires commitment. And again, I say this all the time, I'm going to say it one more time. This is on the bingo card. Access to the internet is now a social driver or social determinant of health, period. There's no denying it. So the question is, what are we going to do about it? Taking on the broadband gaps, taking on digital literacy, that's going to be part of our policy solution. I also want to mention that we are moving into what I call the potential golden era of services in the home. The home has always been viewed kind of skeptically, particularly by Medicare and Medicaid, as a site where there could be fraud, bad things happening. And the truth of the matter is, the home is where people are, and traditional medicine, and I don't say this with any disrespect, kind of asks the patient to log off from their job, drive to where the provider is, sit in the waiting room, hope everything runs on time, drive back to their job. And for low-income populations in particular, it's a financial hit to go to the doctor. And that doesn't sit right with me. So we now have to think about the home and the workplace even as a site of service for delivering care. And that's been interesting to watch folks kind of wrap their brain around it. The patient's acceptance, I put another set of statistics in here from the American Hospital Association. Patients are getting more comfortable talking to their doctors using technology. I will tell you, it was the most adorable thing ever. So I am Gen X, in case you can't tell. And so my warranty has expired and I see lots of doctors. And as I was seeing my regular doctors just for regular care in the summer, fall of 2020, they don't know what I do for a living. And they would say, "Nora, look at me, I'm online, aren't you proud of me?" And I would say, "Yes, I'm very proud of you. How's it going?" "I'm terrified. I don't know how to do this." Well, they'd obviously never been to a TRC training, or they would have been more comfortable. They were doing it very quickly. But once they settled in, they started to see how it can actually build their bonds by more regular contact with their patients. And there is some really great survey data in that third statistic that it's improving patient satisfaction in a lot of cases. And it's not just them not missing work, not driving across town. It's all sorts of use cases that are benefits. So while we're here, while services at home are sort of hot, what do we want to do about it? Well, first of all, I can tell you that moms in particular, anecdotally, I've not surveyed this. If anybody wants a research project, call me or video chat me. Patients are more open to virtual care. And I know with pediatrics, when there's options, they're going to vote with their feet. They're going to go to whoever can see their child the fastest. It's why we have urgent care centers. It's why we struggle with our freestanding ERs. When people need care, they're not willing to wait. And if they can get virtual care, they're going to take it when they can get it. So what we have to do is think about telemedicine and telehealth, not as individual services, but more as tools in integrated environments that are both high tech and high touch. That is not an easy thing to accomplish. But I think for the overall health of patients, it's going to be important for them, especially, for example, for Medicaid patients who are supposed to have a patient-centered medical home. They don't need to be seeing one-off doctors all the time. Now, if it's a Medicaid child, they go to a school-based clinic, we're already asking that school-based clinic to communicate back to their primary care doctor. So we have to build that communication into the system, a combination of high touch with data sharing and tools, and high touch, whether that's in person or virtual contact with the actual provider. These universes have historically not talked very much to each other. Electronic medical records doing their thing over here. Telemedicine doing its thing over here. Texas Tech has done both. And I think it's been to the Health Science Center's great credit that they've developed expertise in both of those service lines. But when I look across the board at the ecosystem, I don't always see it. Those are going to be the services of the future, and those are going to be the services patients prefer. What we do know is time and time again, they'll say, I'd like to see my doctor, but if I can't, I will see any doctor that will see me. And that really shouldn't be an acceptable place. Maybe their doctor's not available, but the system or the office that they see has to be thinking about options, because now virtual care is available and people will vote with their feet. The final thing that worries me is we have a plethora of online services for everything from hearing aids to erectile dysfunction drugs to therapy. We got to be communicating across, and there has to be data sharing, or I'm worried that there could be potentially negative impacts for patients. So integration, interoperability, health information exchange, data exchange, all those concepts belong in the telemedicine universe. I think that's just really important. And then let me close by talking about social determinants or drivers of health. It's never been more important to reach to our vulnerable populations. We all know what COVID highlighted. We all know about broadband access. We also are seeing growth in things like online cognitive behavioral therapy that's done by a prescription. You'll sometimes hear these called prescription digital therapeutics. We have a massive mental health worker shortage. Like, we do not have enough people for the mental health crisis that the whole country's in. So as we build more sophisticated tools and they get passed through the FDA for consumer use, you're going to see those growing in popularity. And of course, you need access to the internet to get to them. And like I said before, the baseline tools are succeeding, but they've got to have better integration. It's going to be essential. And if you look at the trade publications, you'll see that a lot of the major EHR vendors are now linking deals with major telemedicine platforms. And it's going to be very interesting to see how all that competition sort of shakes out. The truth of the matter is our healthcare system was barely meeting our needs in a lot of cases, and then COVID really exposed those weaknesses. So not only do we need to shore up our existing systems, I don't panic easily. So I'm just going to say gravely concerned about the wave of unmet need based on delayed testing and delayed care. So the National Cancer Institute has stated that just looking at cancer screening for breast and colorectal cancer, we may lose 10,000 additional people that could have been caught by screening because they missed it during COVID. That is just tragic at a level I can barely begin to articulate. And it's not just cancer care. That is a data point in a bigger ecosystem. And we also know that low income and underserved populations have less screening to begin with. They catch their disease states later, and as a result, their outcomes tend to be poorer. And that runs the gamut from maternal health all the way through end-of-life care. So this is probably the most pessimistic piece of this presentation, and I hate to be a downer. I am inherently an optimistic person, but we have to remember that telemedicine can do a lot of things, but it's not a cure-all. And in fact, anybody who tells you that you can do everything with virtual care is probably selling something, and you don't want to buy that thing because that doesn't reflect the reality of the healthcare ecosystem. We're not ready for at-home mammograms. We may be someday. I would love to see like a breath test for strep throat. Can you imagine if you could blow on a piece of paper and it could tell you if your kid had strep throat? We can do a Bluetooth otoscope, and hopefully you don't perforate your child's eardrum, but properly trained parents can show the inside of an ear to a pediatrician on call using telemedicine. All these use cases are important, but if we don't also focus on reaching people for prevention and screening, they're going to come into the system too late and with higher needs. And one of the places where telemedicine has really proved itself is avoiding some of those higher cost areas of care. We really have to do aggressive follow-up in those underserved communities to get them to engage. We've got to work on cultural competence and making sure that we meet people where they are. We have to integrate these social drivers into reimbursement. And we have to be flexible with our care models. So, well, that's the way we've always done it, is just no longer acceptable. And thank goodness, I think it's a little bit easier to move that now. So this next phase should be more patient-centric. Health systems will be more integrated. We will have artificial intelligence and machine learning in supporting roles, not diagnostic roles. We're not ready for that. And really, you have to look at patients, providers, and payers when you're talking about SDOH, because they all have a role to play. And I understand people always say, what about the uninsured? There's not a payer. The payer is actually the taxpayer. The taxpayer pays the burden for the uninsured. So there may not be a health plan, but somebody is paying that bill. And at the end of the day, that's frequently the taxpayer. So you can't leave that out of the conversation. We've got to move to more of a patient-centric approach. So to sum it all up, the health IT ecosystem goes. We can absolutely review what works, make some modifications, and jettison some old ways of doing business. And I just really believe in this. Keep the patient at the center of the conversation, but don't overburden the providers. I know providers have screen fatigue and alert fatigue and technology fatigue, and I have nothing but sympathy for their situation. So we have to make sure that the tools that we use are also keeping that provider in mind when we build them. Patient at the center, don't overburden the provider. Practices, hospitals, systems that crack that dynamic, that get that right, are going to flourish in the new environment. So that is my contact information, and I will share my stuff with everybody. And it looks like some of these questions have been answered. Okay, here's thank you to the TRC staff for handling those. That is awesome. How can we expand eHealth to advance global health when there are different policies and licensure requirements? So I'm working on a very, very great question, and I'd love to hear Dr. Santos's answer. Part of my answer here is going to be working on standards. So I'm actually part of an international standards organization work task force that is building an international standard for telemedicine implementations. And it's going to be tools like that that are going to help standardize the policies. Licensure is a little trickier, but policy standardization will take us a long way. And Dr. Santos, please chime in with your opinion, but that's one tool that I think has enormous value as organizations like ISO putting templates forward to help everybody standardize their practices.
Oh, thank you, Nora. That is a very tough question, Dr. George, but it is a great question because I think there's a lot of benefits on that, to make sure that we could potentially deliver those healthcare services to poorer nations, but at the same time, to make sure that the other nations, will not be taken advantage of, in the process as well. We want to make sure we deliver healthcare to the other countries, without issues on. We want the equity. We want to make sure they get access as well, but we want to make sure we want it to be safe as well. Currently, there's no regulations, and I'm glad, Nora, you're involved in making that regulations, because I think there should be metrics as well. I completely agree with that.
Yeah, metrics are a really important part of the ISO process if you're not familiar with the International Standards Organization. And it's got to be done with a lot of scrutiny, because in some countries, and India is an example, when ISO adopts a standard, it becomes India's standard. And they have to build their programs and policies and processes and implementations to that standard. We have a lot of places in the United States where that's required, in manufacturing and other spots. So I had a artificial intelligence developer say to me the other day, I'm an ISO shop. And that means I got to meet all the regulations, all the rules. I got to have my checklist. I got to make my list, check it twice, the whole 9 yards. So it's an international effort, which is extraordinary to me and very, very exciting. And that Texas is helping lead it, because We do a lot of this. We have a lot of experts here. So there'll be a chance for public comment on that, and I'll get that to the TRC and they can share it with everybody for people to weigh in, because all those standards do get posted for public comment. That was a great question.
I know that was, I have to say, I when I saw that question, I was like, Dr. George, the best thing is that there's no punches pulled here. But I also think that the thing to think about with this is that a lot of times the way things work in a global manner is that, you know, the problem gets solved somewhere, where sort of becomes a solved problem, and then it gets expanded out. And telemedicine still feels like it's still so quickly evolving and changing that it's very difficult for them to put things out, because then, you know, it's a very quickly changing environment. And that's unfortunate, because it does mean that it takes longer and longer and longer for us to get that information to the people who need it the most, because we're still working on it.
Nora, there's a comment from Dr. Billy Phillips here. You know, thank you for your sustained service to Texas and to telemedicine. You are a champion and inspiration for many of us. So I'd just like to convey that from Dr. Phillips.
Thank you, Dr. Phillips, who has been my partner on this for many, many years, and to the whole TRC and your leadership. The work that you do is incredibly important. The leadership that the TRC is showing with the echoes and all of the information that's available to people, it's the place I send people. I say, have you talked to the TRC? And they go, no. And I say, guess what? We have a whole group of people dedicated to helping you get this done. And so I know you were an invaluable resource during the pandemic, and the leadership from Texas Tech, who's been so deeply involved in this for so many decades, just continues to show what's possible, frankly, serving a very difficult area. To Derek's story about broadband access earlier, I mean, you didn't pick the easy, low-hanging fruit by being in West Texas. That those are challenging spaces, but also people that creatively problem solve like nobody's business. So it's really impressive what the TRC does, and I'm tickled and delighted always to be a part of any of your events and see what is possible for all of us to accomplish together. This was a fun presentation for me to put together. It took pieces from different things I had done, and I really enjoyed getting the content prepared and having the dialogue along the way. Also, just praise to whoever was running the chat, who was popping those links up and bringing that information forward. I'm beyond impressed.
That is our Texas Tech University Health Sciences Center librarian, Dan Stewart.
Well, my goodness. I wish the legislature had one of him assigned to every member, like over the course of the legislature. That would be enormously helpful. I thought that was great, because that information would have made my slides virtually unreadable, and just to watch that running in the chat, that was just, I've never seen anybody do that before. It was incredibly impressive. So cool. And the whole event is amazing, great content, and I really appreciate getting to be part of it. I guess we could fit in another question if there is one, but I'm also happy to give a tiny bit of time back, because it's the end of the day.
Nora, I have just a quick question. You know, if you have a magic wand and you are the telehealth godmother, there you go. What do you want to change, add, or recommend in our state and federal, law?
Wow, one change I could recommend in state and federal. Let me think about that. So I think I kind of telegraphed my federal change, which would be for the restrictions, for Congress to lift the restrictions on Medicare telehealth. I think that is an incredibly critical piece when you think about that population and their cost to the system. To cut them off from a tool that could keep them out of the hospital makes no sense to me whatsoever. So I think that would be my question. In terms of Texas, I'll give you a hint as to where my magic wand is pointing. I point it. So I give some fair warning before it fires off little sparkles at people. We have not standardized a lot of our documentation and regulatory processes to fit with virtual care. If I see one more thing that says, please send a fax with the information to, I'm going to lose my mind. It's so frustrating. And we have different documentation requirements for different levels of professionals even. from doctors to nurses to LPCs to social workers, so on and so forth. So the House Public Health Committee is going to be looking at this at a hearing in September. And I just think we don't talk about administrative simplification enough. We want to build these integrated systems, but what we really do is we copy the paper process and just make it electronic. And I would like to make that illegal. And ban fax machines. Yes, that also I think would be good. But we have to build this digital ecosystem to be a digital ecosystem, not PDFs of faxes. That's not going to cut it. So I think accelerating that process, would give our providers some breathing room, because this is the complaint that I hear again and again and again, is that they're drowning in administrative stuff. So anything we can do to improve that, if my wand could make that happen, I consider myself a very lucky person to wish for it. So those would be my two recommendations. Pretty concrete, I think. But I also feel like if I could make them real, we would see enormous benefit for patients and for providers. And that's what I care about. That's a great question, though.
Nora, we are so glad that you were able to come out and we got a chance to listen to you speak and present a lot of these things. And hopefully it helps to inspire the people that were here today. It helps to inform them, helps to inspire them, it helps them to carry forward that idea that telemedicine is a great driver of change. I like the idea that we talked about social drivers of health, but telemedicine is a great social driver of positive health, and it can
Absolutely.
be. And I think about, that might be something that eventually I'd like to see that on our charts and graphs, like access to telemedicine. In 5 years, maybe that's a thing, and it's a huge number, and that would be a great way to really look at data. So
I love that. And I think Texas Tech is well positioned to be a leader in getting that framing solid and then getting that communication out. Derek, I mean, you guys just do really great work. And I think what you just articulated is something that will resonate with an awful lot of people who still aren't quite sure what's going on or what they should do next. And they're going to look to y'all for leadership. So I like that a lot. And I was just delighted to be able to be a part of this today.